Good morning, friends. Welcome back to this amazing VMR on Tuesday. We are fortunate to have with us Dr. Singh today, and I can also see my wonderful team members, and I will mention each of their name. So we have Miss Madelina here, we have Yasmin here, we have Hans, we have Dr. Resig, we have Amanda, we have my friend David here, and we have Dr. Singh. And it will be great if we can have somebody present a case to us, if somebody wants to volunteer. If you do not have a case, then please don't worry. Please sit back, relax, and enjoy the clinical reasoning, and try to participate in the chat as much as you can. And we look forward to a very nice learning experience today. And in case if you don't have anybody present a case to us, we also have a backup case thanks to Madelina. So excited for today's discussion. Dr. Singh, do you want to say hi?
Oh, yes. Happy Tuesday, everybody. I was going to say happy Friday. We're 2 days into the week, so hopefully everybody's having a great week, and absolutely stoked to be here with a good friend, good bro, Kirtan. We're lucky to have him for this last week and this week, so before he goes off to ICU. So I thought we'll get him in to go discuss and learn from him. And also great to have the team here, David, Amanda, Madalena, Hans as well, Yasmin, great to see everybody. And before we get going, I just want to throw out there, if anybody has a case, step on up and see if you could present. It doesn't have to be a complete case, but we'll really appreciate it if you have a case we can discuss. Kirtan, how was your trip? It was great. I was really shocked to see you on Friday when Ravi had the camera and he turned it and he's like, you appeared out of nowhere.
Yeah, I mean, that was the plan, to give shock to everybody that like, how can this happen so quickly? Like I was just on the VMR like 2 days ago discussing a case, and then I'm there in San Francisco. But yeah, it was an amazing trip. I got to meet so many wonderful people. I got to witness the clinical reasoning, firsthand. I get very close distance that how they think, how they practice the medicine. And it's always humbling and always inspiring to see. It motivated me to go a step further, to give more dedicated time to studying, to have a detailed analysis of every case that I do. And I'm happy that I got to witness that just before I start my ICU, because you know that in ICU, it's not just about mentally being there, but also it takes a physical challenge, because there are long working hours, things are complex, people cannot make it sometimes, and that's emotional aspect as well. So I'm happy that I got to learn about all of those things, the emotional domain of medicine, the cognitive domain of medicine, by wonderful people. Ravi was there, Jack was there, Dr. Dhaliwal was there. It's amazing. I'm so happy, and thank you again to them.
All right, I got to punch my ticket to UCSF, go get some dose of motivation as well. So that's always inspiring. It's always great to move out of your silo and go see the world of medicine outside of where you're practicing or learning, and really get motivated. And like you mentioned, starting ICU, it can be emotionally challenging because you're dealing with very ill patients, maybe that are at their end of life. So that can be very emotionally devastating. Mm-hmm. And also the cognitive workload is immense with the amount of data that you're responsible for, namely like the respiratory issues, the ventilator, the hemodynamics. So it's great, but it's also a challenge. But I think you'll do really well. You'll have no problem with that. Let's see any case. Oh, we have somebody's asking to be a discussant. I'm going to ask Helubeza. Are you able to unmute your mic?
Yeah. Yes. This is Helubeza.
How are you?
Good.
Could you tell us where you zooming in from?
Yeah, I'm zooming from Georgia here in Atlanta.
Oh, okay, great. And is this your first time coming on, or you joined before?
I have been just following and participating for like the last 2 months. And today I just was to be a discussant if it is possible.
Oh, sure. We can team you up with Kirtan if you want to, and you can discuss, and I'll sort of hang in the background, and if there's anything I can help you with, I can definitely weigh in. But Kirtan, we do that. Yeah, that's great. Somebody wanting to have a go in the lukewarm seat.
Yeah, sorry to interrupt, Dr. Singh. I think Joy T also volunteered. So now we have 2 volunteers.
Oh, okay.
So I think I can help with the scribing and teaching whatever is required. And then you can, discuss with them. We have 2 discussants. So it's always nice to have new discussants.
Sure. Joy, are you able to unmute your mic and also introduce yourself again? It's great to see you on here.
Thank you.
Sure. Wait, what's going on here? Do you guys hear me?
Yeah, we hear you.
Okay, okay. Because like I'm using something else today. So yeah, Kurtan, you're such a gentleman, letting me discuss. Thank you. Thank you. Nice to hear about you going to San Francisco. California is definitely one of the best places in the US. I would say that. And people there are so nice. They're cool. They're a bit relaxed than here in the East Coast, I would say.
Great to hear from you, Joy, and I really appreciate you stepping on up to discuss. And we'll hang back, but we're here. If there are any issues, just ask one of us, and we'll jump in and also help you discuss. So I just want to ask, Helibeza, is that how you pronounce your name? Am I pronouncing your name correctly?
Yes, Helibeza.
Helibeza. Okay. Well, we'll do, since this is your first time discussing Helibeza, we'll have you take a stab at the first aliquot, then we'll alternate. So I don't think there's a case. Anybody volunteer a case? Otherwise, Madalena, we can. I have cases, but I didn't pull any up for today. But do you have a human DX case that you have as a backup?
Yeah, no problem. I can. So this is not a case I personally saw, but this is a human DX case that I'm happy to present. So let me go ahead and share my screen so I can scribe. And yeah, really looking forward to your discussion, Joy and Helibeza. Thank you so much for volunteering. All right, so jumping into it. So this is a 44-year-old woman presenting with dizziness and palpitations. So I'm going to give you a little bit more of the HPI here. So this 44-year-old woman is reporting tremor and palpitations. She said that this has been episodic since 1 year ago, but has noticed the tremor and palpitations increasing in frequency. So now multiple times per day. The tremor and palpitations are associated with malaise, sweating, sometimes associated with confusion and loss of consciousness, but is alleviated by eating. It's a lot of information, but I'll pause there to get your thoughts.
Okay.
Helibeza, you want to take a crack at that? What do you think?
Yeah. Thank you. Just just to start with the fact that this patient is having this thing for quite some time and with increasing frequency, and it all tells us something chemical, hormonal problem, which is coming and going and giving her the symptom and then coming back. And again, now maybe that frequency has increased. So the top on the list, what I was thinking is something hormonal chemical thing is being going on. So from the hormonal thing, top on the list, what came into my mind was insulinoma has came into my mind, and even pheochromocytoma has came into my mind because she might have, with that palpitation, she might have some increased blood pressure. And the other thing now, I was thinking first when I just heard about only the dizziness, I was thinking some neurologic, but now, it could be due to the fuel, and other thing, it could be thyroid problem, and but it doesn't give us that much, a symptom which comes and goes. It usually, when it is a thyroid, it persists for quite some time. It's not paroxysmal. So these are my thoughts which came into my mind. And the other thing, cardiac problems. this woman might have some arrhythmias, which are coming and going, and so I want more infos about her history of hypertension, diabetes, and the like, and past history, and does she have any associated sweating or other increased sympathetic or symptoms. So I need more info on that line.
That's an absolutely great start, Helabez. I just like you looking at this through the lens of chemicals, namely also you could have metabolic issues in there and endocrinopathies in there as well. So I like how you're pulling it all together. I'm going to ask Joy to see if there's anything else that comes to mind with these constellations of signs and symptoms.
So, well, first, system one thinking for me here would be autonomic, since I'm more inclined towards neurology. So yeah, autonomic dysfunctions such as given female, youngish, I would think of like PATS here, and those other spectrum of autonomic dysfunction in a youngish female. And is that accurate data that when they're having it, they actually have lack of consciousness? Like at this point, it's looking like a syncope to me, though. There's palpitations and obviously we have to think of something extra neurological here first. And as the previous discussant elaborated or has discussed already. So yeah, those were my thoughts. I would add autonomic dysfunction to our differential here, but that's very interesting that if they did have some type of loss of consciousness, and for how long, and were there other like some sort of when they have this loss of consciousness, I'm also obviously asking if there are like were they having some sort of movement disorders here while being loss of consciousness, and were there some sort of bowel bladder dysfunction, and ROS here would be very interesting. Yeah.
Oh, great thoughts there, Joy. I like that system one thinking, pulling in all these triggers, all these different signs and symptoms that are suggesting triggers. And I like this thought of maybe hypoglycemia can explain these tremors, and then this sweating as well. The palpitations, I'll kind of put that to the side. Maybe I'll ask Kirtan to weigh in about that, but let's just talk about these tremors, dizziness, sweating. Also in the chat, people have mentioned some great thoughts. There's some endocrinological emergencies that could explain this, but at this point we don't have, like you mentioned, Joy and Helabeza, we don't have enough data to really go down that route. So right now I'll just still kind of stay where you are thinking about all the different directions that we can branch out into. So autonomic dysfunction is very interesting, but if I just take palpitations by itself, I always consider, as some people like Jack and AMK have mentioned in the chat, primary cardiac disorders, arrhythmias, and so on do come into play. Could this be an intrinsic cardiac issue, or is there something systemic that's happening that is irritating the heart and causing these palpitations? But red flags that I usually think about at the beginning, can these palpitations be something that's ominous? If there was coexisting chest pain with this patient, could there be underlying heart disease? Patient has dizziness, and dizziness, there could be some tachycardia due to impaired blood flow to the brain. So you can have very lethal arrhythmias like VTAC, VFib, WPW, Brugada syndrome, where you can have lack of blood flow, and syncope, HOCM could be another one. Is there syncope near syncope? You mentioned, Joy, as well. That can be also a red flag or ominous sign. I would also ask in the family history if there's premature family history of some cardiac death, something that we do worry about. And also if there's any sort of structural heart disease. So an EKG will be very helpful to namely focus in on if there's a devastating arrhythmia or if there's any sort of structural heart problem, like maybe an LVH, maybe atrial enlargement, or maybe a bundle branch block. Maybe there is a block or something like that, first, second degree, third degree heart block. So things to think about. An EKG will be very helpful if you encounter a patient like this. Putting it now all together with now we have the palpitations, we have the tremor, we have the lightheadedness, we have the diaphoresis. So this autonomic issue or sympathetic overexcitation comes into mind. Kirtan, any thoughts about that? I'm kind of dwelling on the palpitations, but I'm going to pull you in for some help to
Yeah,
maybe really
sure,
think
exactly.
this out. Yeah.
Sure. I think, Dr. Singh, you as well as our brilliant discussions have laid the wonderful framework. I have very little to add. I would just say that, of course, in our case, the palpitations, dizziness, tremors, there are so many things that we can focus on. But as Austin and other mentioned in the chat, that keeping it all together, if it was indeed something like, thyrotoxicosis or pheochromocytoma, then given the fact that this has been going on for 1 year now, it's very difficult to fathom that how they would, still be going on without causing any other trouble. Like if you had pheochromocytoma, which has been sitting in your body for 1 year, then of course it can cause paroxysmal symptoms initially, but over the time it will cause persistent hypertension. It would cause other systemic side effects, which are hard to miss. Same is true for thyrotoxicosis. We know that thyrotoxicosis is a risk factor for atrial fibrillation, and in the right context, atrial fibrillation can account for the syncope, can account for the dizziness, because as you said, that when you have tachyarrhythmias, the blood supply to the cerebrum kind of goes down gradually because the pumping effectiveness of the heart goes down, and that can give you the syncope and pre-syncope. And sometimes as a prodrome of syncope, you can get confusion, although it's less likely. So, but again, if you had thyrotoxicosis since 1 year, then you would have other symptoms. And this severe thyrotoxicosis, which can cause atrial fibrillation, then you would expect that people would, lose weight, people would have changes in their hair, in their body metabolism, and other aspects of their life. So that's why those possibilities were less likely in my mind. And as our discussions mentioned, that autonomic nervous system involvement can also be triggered by hypoglycemia. And given the fact that things were alleviated by eating, kind of pushes us toward that direction. And now the frequency is increasing. So even more impetus is there to find out maybe the tumor source in the body, which is releasing the insulin or insulin-like growth factor, is kind of becoming more aggressive now. It is releasing insulin more often and more frequently. So that's why maybe the patient is experiencing symptoms more frequently. So that's what I was thinking. And I'm excited to see what next Aliquot brings us. Back to you, Meredith. Yeah.
I was just going to add in, that's absolutely remarkable. Like, see what Kirtan has done. He's added that extra layer. Halibeza, Joy, you started off this discussion with some fantastic thoughts. And then, I kind of focused, I got excited about the palpitation. Then Kirtan came in like, these are two very good hypotheses, but a patient having it for this duration, they would have been extremely exhausted and maybe presented much earlier, because these are considered possible emergencies. One thing, I just love this thought about palpitations. Austin's mentioning a lot about it in the chat as well, but I always want to throw out this pseudo or mimics of palpitations. I did a scheme a little while back. We had a case which Ravi discussed. So mimics of palpitations that we also have to entertain early on in analyzing such a case. You have to think about esophageal spasm, reflux disease, hiatal hernia, stomach rumbling, or intercostal muscle twitching. And what is very interesting, there's some of these complaints are alleviated by eating. So again, is that gastrointestinal related, or is it due to this sugar? So very much, I think all of us are pretty much front and center considering a endocrinological issue, namely hypoglycemia. That's clearly in the picture. Are we ready to drop our diagnostic anchor? Probably not. It's still very early on, but let's see with the next aliquot. Back to you, Madalena.
All right, just echoing the amazing discussion. All four of you really all brought such fantastic points. All right, so in terms of the past medical history, so it says here that this woman has a history of anxiety and seizure disorder, but does not take any medications. For family history, this is notable for a mother with diabetes and breast cancer. No history of heart problems, autoimmune disease, or endocrine disease in the family. And then just jumping back to the patient's medical history to give you a little bit more information. So this patient had a hospitalization for similar symptoms 1 year ago. During this hospitalization, she was told she had low blood sugars. The symptoms improved slightly for some time and then worsened again. And after I finish this output, I'll go back to the whiteboard and update it for those who, if you didn't catch all that. And I'm actually going to give you the information about the physical exam. So it's a little bit limited, the information we have here, but it says normal vital signs, a BMI of 32. In general, she appears comfortable and healthy, normal heart exam, mental status, and neurologic exam. And I'll actually give you one more piece of information about the patient's occupation. So the patient is a patient care assistant for a home health company. And I will pause there and kind of add all this information to the whiteboard so you all can see.
Okay, now it gets interesting. Joy, you want to start off before it was Helabeza, but I'll have you take a first stab at that.
Yeah, so given this information of that they had this similar episode in the past that really brought them to seek and they were hospitalized for it, and it's at this point it's looking more like, to me, I'm thinking insulinoma here, possibly, given that they were hypoglycemic and they're like multiple times a day or episodes, and or a syndrome, not, you know, those syndrome that has insulinoma to it. So also obviously it's not yet a good time to anchor on anything at this point also, and definitely thinking about endocrinopathy. It's like could be also it's interesting to me that they have a seizure disorder and they're not taking any medication. So I'm not quite sure if that is like another problem that they have here, or that could be a potential unifying diagnosis that there is actually one diagnosis that we're looking at here. So yeah, that's why I have now.
Great thoughts there, Joy. Yeah, it's not clear yet. Yes, insulinoma is a great thought. I definitely am also thinking on that high up in the list of potential possibilities. I'm going to ask Helabeza, see what he thinks about this.
You know, thank you. You know, having the Whipple triad, having these three symptoms is more suggestive of something in, you know, which is going on with insulin. And the question is, where do we get this insulin? Are we having this insulin from a tumor secreting from inside the body, or is it something coming outside of the body? So obviously, the fact that she has that Whipple triad tells us that she's having hypoglycemia, the blood sugar is low, and she's having all the symptoms for hypoglycemia. And it was confirmed by last year admission that her blood sugar is low. And the third one is it is relieved by eating, which means it is something hypoglycemia. And that hypoglycemia is induced by insulin for obvious reasons. The question is, where is the source of insulin? is this being secreted by a tumor from the body, or is she injecting herself the insulin? And from the occupational history, we have got that this patient is a patient care, and she might have an access for insulin. So I want, for this, before jumping into imaging and other modalities, I want the insulin and the C-peptide level to be checked even before other uh, imaging, other techniques, because this patient might have an access for insulin. So I will go from there.
Great thoughts there. I couldn't help but have the sort of same thought process there with the occupational history. We always learn during the exams of exogenous insulin, occupational exogenous intake of insulin causing this, and the labs will be very helpful in that case. But thinking broadly, so system one would be, yes, maybe somebody taking exogenous insulin, non-diabetic patient. I would kind of first establish, is this patient diabetic or not? There's family history of diabetes, but this patient doesn't clearly have history of diabetes in the past medical history. So exogenous use, or is there an endogenous cause of insulin that's responsible for this? So an insulinoma, namely, could be a cause of this. Could there be some sort of insulin sort of autoimmune process causing hypoglycemia? Could there be some sort of adrenal insufficiency maybe that's causing this as well? Other causes, malnutrition could also be a cause of hypoglycemia. So we have to be careful that it's not system one thinking is drawing us towards an insulinoma, but there could be many other reasons. There's a couple that I remember, but other reasons that we have to think about. And we do want to highlight that there could be exogenous intake of insulin. So getting the labs will be very important too. Helabez, I really like that you had mentioned the Whipple's triad. So it clearly, the history does establish that there's neuroglycopenic symptoms. Is there a low sugar? We have to have at least less than 55. I forgot the units of the blood sugar established, and then it's corrected, or the symptoms are corrected by giving giving some glucose. So if you meet the triad, then definitely there's hypoglycemia due to one of these hypotheses that we're thinking about currently. I want to rope in Kirtan to see if there's anything that we may have missed in our reasoning.
No, Dr. Singh, I think you guys are spot on that before jumping into the imaging modalities, which can be expensive and can be misleading as well, because we always know that whenever you image somebody, there is a significant chance that you will find what is known as incidentaloma. That is the whole point of ordering the biochemical tests in the endocrine world, because if anybody has any sort of endocrine problem, and if you think about, okay, let's image the pituitary, then there is a very high chance that you will find an asymptomatic adenoma, and then you will go down that route of figuring out that what to do with that. Same is true for adrenal incidentalomas. So I agree with Helibusa that getting the C-peptide and the insulin levels first to figure out that what's going on can be very important. And I also echo the sentiment which you mentioned, Dr. Singh, that although it is tempting to go down the path of excessive insulin or insulin-like products causing this symptomatology, but we also have to think about other possibilities, like what are the most common things which can cause hypoglycemia. So the drugs are very common reasons for that. And when I say drugs, I also mean to say the illicit substances. So things like alcohol can impair the hepatic gluconeogenesis and can cause hypoglycemia. Opioids can chronically cause pituitary suppression and can cause adrenal insufficiency and can contribute to hypoglycemia. Then lots of medications. So all the anti-diabetic medications in the right context, classically the sulfonylureas and insulin secretagogues can cause hypoglycemia. So we will like to see that what are the over-the-counter supplements as well as the medications which the patient has been taking. Fortunately, in our case, patient doesn't seem to be on any of the medications. Then we move to the endocrine world. So we think about chronic hepatic failure like cirrhosis, chronic kidney disease, because both of those are important sites of gluconeogenesis. then thyroid dysfunction. So classically, hypothyroidism and adrenal insufficiency, all of them can contribute to hypoglycemia. And when we move down the path of insulin secretion, then we have to ask ourselves that could this be exogenous insulin? And of course, the C-peptide levels can guide us. If the C-peptide levels are low, then our suspicion is that this patient might be taking exogenous insulin. If the patient is taking exogenous sulfonylureas, then the C-peptide levels will be high and we cannot differentiate between them very clearly. Lastly, what else can cause apart from insulinoma to present in this manner? So we have something known as nesidioblastosis. So like beta cell hyperplasia. And I remember this because like just 3 or 4 weeks ago, in our weekly VMR teaching emails that you get when you subscribe to CP Solvers, it was written by Andrew Sankes, if I'm not wrong. So they had mentioned very beautifully that how you can get nesidioblastosis, kind of like beta cell hyperplasia, and how that can contribute to hypoglycemia. Usually it is seen in people who have underwent the bariatric surgery, which contributes to the hyperplasia of the beta cell. So that is one pathology. Very rarely it happens that sometimes tumor can secrete IGF-2, which is known as insulin-like growth factor type 2. And the reason why IGF-2 is important, because usually IGF-1 secretion doesn't classically causes hypoglycemia, because IGF-1 binding protein kind of binds to IGF-1, and therefore the levels don't reach the high enough level. But IGF-2 is not subsequently bound by the IGF binding proteins, and that's why IGF-2 has access to all the insulin receptors in the body, and it can contribute to hypoglycemia. And then, of course, there are very rare disorders like autoimmune insulin syndrome, like autoantibodies against insulin and things like that. So firstly, getting the C-peptide levels and insulin levels can guide us. And if those results are suggestive, then we can move ahead with the imaging studies. So I think that's how maybe we can.
Oh, thank you, Ketan. Great walkthrough of a schema for hypoglycemia, like you mentioned, endogenous or exogenous use. And they're both pretty much in the running for contention of hypoglycemia in this patient. So we'll see with the next aliquot what else we have that we can really decipher to get to the potential diagnosis. Back to you, Madalena.
All right, so you all asked for C-peptide, so I will give that to you. Okay, so the serum glucose was 37, concurrent insulin was 20, and C-peptide 4.4. Both of those values are high normal. The beta hydroxybutyrate is 0.11, creatinine 0.6, and the LFTs were normal. And I will pause there to get your thoughts. And we have 2 more aliquots before the end.
Okay, great. Thanks, Madalena. Halabeza, I'll let you take a crack at that and see what you think.
So do we have any oral hypoglycemic, blood level checked before that? So if we have that would be nice. Otherwise, the Whipple trial now we see that hypoglycemia and symptom and relieved by eating, it fulfills, but it doesn't tell us whether it is exogenous or endogenous, because as we have said, it could be from the insulinoma or other tumors secreting insulin, or it could be by oral hypoglycemic agents, which will induce insulin secretion. So we need to have that info to just, we are still, we are stuck in there.
Absolutely. Great thoughts there, Halabeza. I want to ask Joy, what do you think with this data, what Halabeza has gone through?
Yeah, I agree. This information that we have with the C-peptide and the insulin being both high normal, that to me, it's more likely this is something endogenous insulin we're dealing here than exogenous that we were thinking earlier. So yeah, and whether that insulin is coming from like the pancreas or there is a bit more that's going on here. I don't know yet. Yeah, so definitely we can rule out exogenous insulin.
Excellent, excellent. So now it's becoming more clear cut. We can now follow the branch point of endogenous, since the values are high. I think if insulin is greater than 5, that clearly is something endogenous. And insulinoma was a thought, but we also, like Kirtan mentioned, all the other possibilities of endogenous hypoglycemia we may have to entertain. And the serum glucose 37, we've established that this is clear cut. We need a lab value less than 55 milligrams per deciliter to determine hypoglycemia. So there's a clearly hypoglycemia. I'm gonna send it back to you, Madalena, for the next aliquot.
Great. Okay, and actually for the sake of time, I might give you all of the information up to the final diagnosis so that you all can discuss. So we have here that the glucose recurrently dropped below 50 with symptoms until a dextrose infusion was increased to D10 at 100 cc's per hour. So the last piece of information I have is the CT abdomen, and that showed a 1.4 centimeter round enhancing lesion in the pancreatic tail. And that's all the information I have.
Oh, very interesting. I'm gonna send it back to Joy, since you just, I guess you ended the last discussion. How does this information help you now?
Well, enhancing CT on in the pancreatic tail, that to me says it's insulinoma until proven otherwise. So yeah, given that they continuously having drops of below 50 glucose hypoglycemia to this severity, I mean, and with this CT imaging that we have, yeah, that's what I was thinking, insulinoma until proven otherwise. So
Absolutely, absolutely. Helabeza, any last thoughts before we get the final diagnosis?
Yeah, the final diagnosis as we have just it clearly it is insulinoma, but the next question is, could this patient have, somewhere else metastasis, or we can get this insulinoma in other parts of the body, even in the chest, in the liver, and the CT scan is only abdomen. Does it include the chest? And the fact that the symptoms, the frequency of symptoms is increasing, it shows us it's fast growing. So it's growing. Now this patient has only one lesion in the pancreas. What about somewhere else? And we need to see if this patient has any other, like the multiple endocrine neoplasia, because insulinoma is just one. What about did we see the calcium level here? And because the hyperparathyroidism could be there, because in case of men, the endocrine individual disease could happen at different time. One may precede the other, and this patient might have only now insulinoma, but she might have other the other endocrine problems or neoplasia next, or she might have occult one, and we need to investigate even for that.
Absolutely wonderful. Both of you are sort of unfolding your reasoning in, okay, we have this thought here, maybe with this imaging that we have, but still keep an eye on possible other causes. I like the use of MEN 1. Do we need to work further or not prematurely just close the discussion and leave it at that? But MEN 1 would be something to consider. What if there's something else ailing and we didn't really do our due diligence in working the patient up further? So getting those labs definitely will help to see if there's any hyperparathyroidism. Could there be also pituitary involvement with this patient? So something to consider. And then see if there's any, like you mentioned, if there's any metastatic lesions anywhere else that can manifest like that. But yeah, neuroendocrine tumors definitely were possibly in that domain. And then I'm going to send it back to Madalena for the next aliquot? Is it the final diagnosis of the next aliquot, or the more information?
That's all the information. So
Oh.
the next piece is the final diagnosis.
So,
Any final thoughts, Joy or Halabeza? I think.
so I think we can, at this point, this is the final information we have. We can, so the other chemistries that we were wondering, like the calcium, to consider the MEN syndromes. Probably
I think you can
normal.
assume the calcium's normal.
They're normal, right? So
yep.
I think this is insulinome just in the pancreas. There's a benign lesion and growth in the pancreas that's making a lot of insulin for them. So that could explain everything that they're having, the presentation here.
Yeah, and going back to what Keithan mentioned, like some of these things can be very devastating. And how is this patient having these issues for such a long time? But as it's highlighted in red there, patient has been eating or figured out that eating has helped alleviate these symptoms. So that's kept the patient outside of the medical system from seeking help. But it came to a point where patient is, again, it maybe these symptoms are ramping up and she isn't able to control them with eating. And patient's been hospitalized in the past for similar symptoms. So it's something that's a little confusing that this wasn't worked up or they didn't explore further. So something that we may cross paths with, and something that we may have to recognize if we have a patient like this. So a lot of great learning from this case. I'm just going to ask Keithan, any thoughts about our thinking that you can weigh in on before we get the final DX?
No, I think I totally agree with you guys that given the fact that the Repulse triad was fulfilled, we have the definitive imaging studies, and we have no conclusive evidence that the patient was taking any other substance. Then I think we have our diagnosis. It could be the insulin secreting tumor, and hopefully the patient will do well after the tumor is resected. Amazing discussion. I just want to mention that it's the first time that I'm hearing Halabeza discussing, and I like that, how he is going one step ahead. Like he's just not stopping at insulinoma. He's thinking that, oh, could this be part of the MAN1 syndrome? Could these be other tumors? And same, I applaud Joy T as well, that how from the first aliquot itself, she jumped to the fact that could this be dysautonomia? And then how we can get hypoglycemia to that. So just wanted to applaud that how they rightfully got the diagnosis. So happy to see that.
Yeah, same here. Yeah, great job, everybody. Great teamwork. I'll send it back to Madalena to tell us what they found.
All right, fantastic discussion. And just echoing what Kirtan just said, you all were spot on. And I really appreciate how a lot of you mentioned, beyond your concerns with this final diagnosis, is there like an MEN syndrome? So I thought those were all great points. So ultimately, she was diagnosed with an insulinoma based on clinical, biochemical, and radiographic findings. So in terms of follow-up, an endoscopic ultrasound ruled out satellite lesions or local metastasis. She underwent a distal pancreatectomy with pathology confirming a benign, highly differentiated neuroendocrine tumor. Close family history and further evaluation did not raise concern for MEN, multiple endocrine neoplasia. She had an uneventful postoperative course. Her hypoglycemia resolved. So amazing job, everyone. I have here some additional teaching points that's included in this human DX case that I can go over, but just wanted to turn it back to you guys to see if you have any reflections before I give some of those teaching points.
Amazing job presenting the case, Madalena, as always. You're awesome.
Fantastic discussion, Joy. You had it was so wonderful to learn from all of you. Shall I jump into some of the teaching points before Yasmin gives her teaching points?
Absolutely. Really well presented, Madalena. That was fantastic.
Yeah. So some of the teaching points here, let me make sure. Yeah. So most hypoglycemia occurs in diabetic patients as an unintended effect of insulin or other anti-hyperglycemics. It also occurs frequently in acutely ill patients due to sepsis, liver failure, or adrenal crisis. It is outside of these apparent contexts in well-appearing patients without a clear cause that symptomatic hypoglycemia warrants detailed laboratory evaluation. So in terms of diagnosis, laboratory evaluation involves measurement of insulin, C-peptide, beta-hydroxybutyrate, and sulfonylurea, meglitinide levels during a hypoglycemic episode. The expected patterns for each possible cause can be referenced. In our patient, inappropriately high C-peptide suggested an endogenous insulin source, either from autonomous release, like an insulinoma, or from ingested insulin secretagogue. Our patient's history included elements commonly associated with factitious hypoglycemia, so a middle-aged female healthcare worker with easy access to insulin, and it created a degree of anchoring bias. However, her appropriate affect, the time course of her illness, and her persistent hypoglycemia compelled us to pursue imaging early, expediting her diagnosis and treatment. And lastly, a pearl here is that in people with frequent hypoglycemia, the adrenergic response, so anxiety, tremor, sweating, gets blunted. Losing this hypoglycemia awareness is dangerous, as you are more likely to develop neuroglycopenic symptoms such as seizure or encephalopathy. So those are all the teaching points I have, but again, really fantastic discussion from all of you, and I'm eager to hear Yasmin's teaching points.
Hello, amazing case, honestly. And thank you, Helubesa. Thank you, Joy. I'm sorry if I said the name wrong. Please correct me. And for the teaching points, the main approach to this patient, in a female patient, Dr. Helubesa said, consider endocrinologic etiology, insulinoma, pheochromocytoma, thyroid. And we can do the differential diagnosis, determining also the onset and the duration of symptomatology, because as Curtin very brilliantly pointed out, that there are diseases that will cause a lot of symptomatology, and the patient will definitely not be, could not take a long time to go to the primary care doctor and take care of that. So redundancy apart, we also have to determine primary cardiac versus sympathetic drive in a patient with palpitations. We have to look for accompanying symptoms. There are mimics of palpitations. Dr. Ravi brilliantly made a schema. I hope that he can share it with us. About the mimics are the esophageal spasm, GERD, intercostal muscle twitching. So we have to also be very aware of those. Now, approaching to hypoglycemia, which Maddie said that it's an unintended effect in insulin treatment, there are different causes of it. It could be a fasting hypoglycemia. We have to think, are there insulin or meds or alcohol? We have to know that when insulin is self-injected in factitious disorders, labs will show high plasma insulin and low C-peptide levels during hypoglycemic episode. But Dr. Austin also remembered us, be careful with anchoring biases when treating a female patient and patients with mental health diseases. Then there's also the cause of postprandial hypoglycemia that we can think about, rare enzymatic diseases or autoimmune diseases that can affect insulin secretions, other diseases such as liver insufficiency, adrenal insufficiency, hypopituitarism, and hyperinsulinemic states that can be caused by glucagon, catecholamine deficiency, and of course, insulinoma. I also found that there can be an artifactual hypoglycemia due to consumption in leukemia, erythrocytosis, and hemolytic diseases. Dr. Helubesa also said, Whipple triad suggests issues with insulin. So we have to find out, where does it come from? Is it from the pancreas per se, or is it again an issue with it's a factitious disorder? Now, for insulinoma features, we have high levels of C-peptide, high proinsulin levels, hyperinsulinism. These elevated C-peptide and proinsulin levels may also be the result of sulfonylurea used. So rule it out by screening the serum samples of sulfonylureas. And determine if there are MEN1 features. Remember the 3 Ps, parathyroid, pituitary, and pancreas, especially gastrinoma. And again, why this patient had weight gain? Well, because the patients with a high anabolic state eat more. So these are all the teaching points for today. Thank you very much for your discussion for this great Tuesday morning.
Thank you, Yasmin. That was wonderful. Thank you, everybody, for this hour of power. Helubesa, Joy, it was a great honor to listen to your reasoning, to learn and help me or direct me towards what you were thinking. So it was great to sit back and enjoy all of your thinking and diagnostic clarity that you brought to this case. And Madeline, a great presentation. Absolutely great
Thank you very much
case.
for giving me the chance. Thank you very much again.
Thank you. The pleasure is all ours. Take care, everybody, and see you for tomorrow's episode. I think Jack is on with Charmaine, so see everybody there. Bye.
Bye, everyone.